Welcome, everybody, to our World Patient Safety Day webinar on diagnosis from the World Patients Alliance. Thank you so much for joining us. Next slide, please, Harris. I just want to do a quick introduction. As you know, the theme for World Patient Safety Day this year is diagnosis. We have an excellent lineup of speakers on the topic of diagnosis. We have from the US, we have Professor Gordon Schiff from Harvard, who is one of the world's leading experts on this topic and a deep thinker on all the sort of ramifications of diagnosis, especially as they pertain to communication and patients. We have author Diagnoses Linton from Australia, who's going to talk about her multi-year odyssey in diagnosis and other issues. And we have Nurse Cecilia Nantume from Uganda, who's going to describe her own experience of a diagnostic near miss and through the lens of her professional expertise, and talk about some tips for patients to avoid diagnostic error. So we have, the webinar will be recorded. The bios of all of these speakers are on our website. And as always, we will add resources on the website, including the recording of the webinar and including any resources that are mentioned in the webinar. These are resources for patients. So I think that is, next slide, please. Okay, next slide, please. Well, so just a little how we are a multi-language broadcast. In the chat, Haroon will put a link every time a new speaker comes up to tell you how to access this. You click on the link called Wordly that's given in the chat. You select your language, put your name in, and click attend. And then you will get simultaneous translation in your own language. And if you want to change languages, I think that's what number 6 is saying, you can click on unmute. So that should be pretty clear. And as I said, the link is in the chat. Next slide, please. So World Patients Alliance, just a little bit about us. I am Helen Haskell, and I'm chair of the Patient Safety and Quality Council at World Patients Alliance, which is a nonprofit umbrella organization of patients, patient organizations, and stakeholders from around the world with the mission of empowering and raising the patient's voice for access to safe, quality, and affordable healthcare. So our goal is patient empowerment. We work to ensure that patients have an active role in all stages of healthcare, starting at the top and extending down to the bedside and to evaluation. Anyone can join if you're not a member. Any patient advocacy organization can join. Just you can sign up on the website. Next slide, please. So at the moment, we have 619 member organizations. It grows daily. We're in countries around the world. We are the world's largest umbrella patient organization and work across all disease areas. Next slide, please. So one of the things that we do is make short animated videos with tips for patients about different areas of healthcare. So this is our latest video in honor of World Patient Safety Day. We have a little video with tips on, and these are, the videos are very short. There are many more tips that you will hear from our speakers today. These are just a few of the things that you can do to improve communication, to help get the right diagnosis. So Harris, if you could play the video. The sound is off, Harris. There we
When
go.
you visit your doctor, how do you know you're getting the right diagnosis? Diagnosis is the foundation of medical care. It defines what's wrong with you and allows your doctor to treat your problem. If you don't have the right diagnosis, you may not get better. You may even be harmed by incorrect or delayed medical treatment. But diagnosis can be tricky. There are thousands of diseases, and many of them share the same symptoms. Almost every one of us will receive a wrong diagnosis at least once in our lives. Did you know? Good communication between you and your doctor is one of the most important factors for arriving at the right diagnosis. You need to be actively involved. Here are a few things you can do to help get to the right diagnosis. Describe your problem clearly and completely. What does it feel like? What makes it better or worse? If you can, research your symptoms for a better understanding of what they might be. Tell your doctor about all your medications, including vitamins and herbal remedies. Sometimes, the side effects of drugs can mimic other illnesses. Ask questions. Can your symptoms be explained by more than one diagnosis? Ask about the reasoning behind your diagnosis, and be sure the doctor has correctly understood all that you said. Misinterpretation of the medical history is a common source of diagnostic mistakes. Watch for changes in your condition. The correct diagnosis may not always be immediately apparent. And remember, your diagnosis is about you. Don't hesitate to keep seeking answers until your concerns are addressed. To learn more about getting a good diagnosis, visit our website at www.worldpatientsalliance.org. World Patients Alliance, the global voice of patients.
Thank you, Harris. So that is the world premiere of our diagnosis video. It's should be on the website. You can spread it widely. We will try to send it out later today as well. So this is our agenda. We start with Diagnoses, which will be followed by Gordy Schiff, who will give us an overview of the latest perspectives and findings in diagnosis. Followed by Cecilia, who will talk about the nurse's perspective on her own experience and how patients can advocate for themselves. Then we will have about a 15-minute question and answer session. So please if you have questions, just put them in the chat as you think of them, and Harris will ask them during the panel. And then we will have a wrap up from Andrew Spiegel, the chair of World Patients Alliance, who will tell us about upcoming events and things we should be aware of. So next slide, please. These are our speakers: Andrew, Helen, Cecilia, Diagnoses, and Gordon. Next slide, please. So I'm going to start us off with Diagnoses Lenton, who's going to talk about her experience and her interpretation of her experience, the lessons learned. Diagnoses is an author of an excellent book called Battle Scars. She's a speaker and a patient safety advocate. She has spoken at the World Health Organization last year, which is where we had a chance to chat, and how she ended up here. And we will let her open up with her talk. Diagnoses.
Can you hear me?
Yes.
Okay.
Yes, good.
So do I come up in the big screen or just a little screen at the top?
You're on the big screen.
Oh, am I? Oh, I can't see that. I only see Helen. Thank you. Thank you for inviting me. I've got an interesting story to tell you about an extremely rare complication that I experienced following a trip to the OR. And the interesting thing is, it not only happened once, but it happened twice. My arms were partially paralyzed from a complication And the first time it happened was about 30 odd years ago, and my right arm was affected. And 6 months later, I had a brilliant hand surgeon who operated and reversed the paralysis. 20 years later, the same thing happened again after another operation, and this time my left arm was affected. So basically what I couldn't do, what happens is 10 days after the procedure, you have intense pain in your arm, and then you can't straighten it, you can't turn your hand over, you can't bend your thumb and your index finger. So there were a lot of daily functions that I couldn't do. So I couldn't tie my shoelaces, I couldn't type on a keyboard, I couldn't drive a car, I couldn't eat with a knife and a fork, I couldn't send text messages. So I went back to my urologist because that procedure was for kidney stones. So I went back to him and I said, I know what this pain is. I know what will happen. I know my arm will be paralyzed. But he basically said, I have no idea what you're talking about. And he sent me off to a neurologist. And that's where my journey started. By about the 6th month, I'd seen 20 different doctors, and they gave me 20 different diagnoses. And they were all scratching their heads. They'd never seen or heard of a condition like this before. And the only thing that they all agreed on was that the paralysis was permanent and that I would not have any recovery. But I knew that it had happened before and I had recovered. So I thought, I've got to be able to convince them that there is hope and there is an option for recovery. But they'd all waved their white flags and they'd given up. And I realized at that point in time that there's only one person who's going to be dedicated enough to find the answers. So basically, I enrolled in the University of Google and YouTube, and I started doing a lot of research, trying to find the answers. And there wasn't much information available, but I was started to learn about the anatomy of the arm, the muscles, the nerves, the veins, the arteries. I learned about the anesthetic drugs that I'd been given. I learned about how to read MRIs, ultrasounds, X-rays, and neurological tests that were being performed. And during that time, I'm building my knowledge, and I'm also looking for medical papers because I was thinking there's no way that I could be the only person in this whole world with so many operations going on every day that I'd be the only one who's had this happen, not once, but twice. And during my search, I found a paper called Isolated Thumb Interphalangeal Flexor Weakness Following Total Hip Arthroplasty. And the title basically went over my head, but the only reason I found that paper was it was published on the 5th of May. And that's the only reason, because the 5th of May happens to be my birthday. So I reached out to the author, Professor Patrick Weinrau. It was a team of doctors who'd written that article, but Dr. Weinrau was the main author. So I reached out to him and I said, please, you've got to help me. You're the only person who's got some experience with this condition. And he guided me through this medical maze for the rest of my journey. For 14 months, I traveled all over the country. I saw 49 different doctors. And eventually, I managed to convince doctor number 49 to operate. And as soon as he opened up the arm, he could see exactly what the problem was and what he needed to do. My lacertus fibrosis had thickened and it was putting pressure on my median and anterior interosseous nerves. And as soon as the pressure was released, the paralysis was reversed instantly. And 3 months later, I had full strength back in my arm. But it highlighted how very difficult the problem is for patients when their condition is rare. And, you know, because it was so rare, I just couldn't get any doctor to listen to me. And even though the same thing had happened to me before, and I had a scar on my arm, which is, 5 inches long. I still couldn't convince any of them. And it comes back down to how the doctors are taught whilst they're studying. And a lot of the doctors are taught, if you hear hoofbeats, think horses, not zebras. But sometimes it's not a horse or a zebra. Sometimes it's totally different. And I got called a lot of names by a lot of doctors who just couldn't find the answers. I was called a hypochondriac. I was told I was suffering from Munchausen syndrome. I was told I was crazy. I was embellishing a story to create interest. But the story is the patient is the one who knows their body better than anyone else. And that's the message I'd like to give. Listen to the patients. They know what their condition is. And yes, there are some crazy people. I know there are some people suffering from Munchausen's, but I had all the evidence. But the reason why it took so long to get that diagnosis and that eventual recovery was there were so many errors being made by so many different people in the healthcare system. There were missing pages of reports. My reports were filed in other patients' folders. My reports were filed away before the surgeon got a chance to review the results. Radiographers were taking images of the wrong body part. Radiologists were giving inaccurate interpretation of the results. And a neurologist, he was running behind schedule. So he was doing neurological testing on 2 different patients at the same time. And that led me to receive incomplete testing. But the following neurologists were basing their diagnosis on the original neurologist's testing, which was incomplete. And I found that after realizing that I'm not going to get very far with this, I basically stopped taking all my previous test results and got them to start from scratch. And when they started from scratch and they did the neurological testing on the whole arm, I remember my neurologist saying, I can't believe it. Whatever I do, I just can't make your thumb move. So that's my story. So to all the clinicians out there, please listen to the patient, elevate the voice of your patients. If there are patients listening, I'd say keep a record of every visit, every doctor. Thank you.
Thank you so much, Janaz. That was terrific. With a lot of lessons learned that we will talk about in the Q&A. Our next speaker up is Professor Gordon Schiff from Harvard University, who is a longtime friend of mine and one of the world's leading experts on diagnosis. It's my pleasure to welcome Dr. Schiff. I'm not going to take any more time with the bio, but it is on the website, as I said, and he is here to enlighten us on diagnosis.
Thank you, Helen. Am I able to control my slides? How did that Passover work?
I think so.
Yes,
So
yes, you can.
Okay, yeah. I'd like to think the truest part is our friendship that you mentioned. World's expert, I don't know, but we'll touch on a few things.
I know.
Together. So how do I advance the slide? What's my
There you go.
I no, but do I have the ability to advance slides? I thought I did. Where do I click?
Try the arrow on your
Oh.
computer.
Or you can click on your keyboard.
There you go. Very beautiful. Does it go back also or no? Yeah. Backward and forward? Okay.
Yes.
Anyway, no commercial conflicts. These are some of the agencies and especially ARC and our malpractice insurer, the Gordon Betty Moore Foundation, that have funded some of the work. We're really in 20 minutes not going to talk about all the studies we've done or the things we've learned, but just touch on a couple lightly on a couple of big 10,000-foot topics, and hopefully there's a lot of resources you can follow up further. I thought the video was really excellent. I had not seen that. I think I wish I could just spend 20 minutes dissecting that video and elaborate on it. It was really good. This is, I guess, goes without saying, but just one visual. This is from one of the malpractice insurers that shows you that of all the malpractice claims that patients are filing, so this is in some ways patients voting with their feet of what they really have bad outcomes and upset about and feel like they need some better justice. Diagnosis is far and away the leading cause, both in terms of numbers of suits and numbers of dollars. I don't know why this isn't advancing. Okay, this is my goodness, I guess there's some kind of delay here. So, okay, this is again, it's just some research that's been done by members of our leader of our society. Helen and I work with David Toker Newman and the CRICO folks from their database. But it's interesting that a lot, now we just heard about a rare diagnosis, but most of the diagnoses in terms of these malpractice claims fall into three big areas. One is vascular, although you could even think about that neurovascular compression in Dinah's case, but vascular, infectious, and cancer. And again, these break down into these are common diagnoses, especially the cancer one. You can see that's the biggest slice. We're actually spending a lot of our efforts on 4 leading cancers being delayed or diagnosed. And the Institute of Medicine, National Academy of Medicine came out with a report that had a much more elaborate model of the diagnostic process and diagnostic error, but my simple mind can just sort of get around these 3 Venn diagrams. And I think we see lots of diagnostic process failures every day. The doctor doesn't examine the patient, there's missing information, blood samples are switched. Usually it doesn't lead to a misdiagnosis. Let's say somebody's blood sample switched 21 bed A and 21 bed B, and their sodium is too low, and then it comes back low in a patient unexpectedly, but then they repeat it so they don't misdiagnose this patient. But as opposed to Linda McDougall, who was one of the patient advocates on the cover of Newsweek, she woke up after her breast cancer bilateral mastectomy, and the surgeon says, "You don't have breast cancer." She said, "I'm so glad you cut it all out." She said, "Actually, you never had breast cancer. So we switched the pathology specimens between you and another patient." So obviously she had a misdiagnosis and adverse outcome. Thinking about the case we just heard, lots of things went wrong. The lab result went to the wrong folder. Someone misinterpreted the x-ray as I heard this. People were rushed and they didn't have time to do a good history. They weren't listening to the patient. These things are often happening. And of course, there's no defending these. And in fact, this is the only way we're going to prevent these is by looking at those process failures that we just heard about. But in your case, there was definitely a delayed or a misdiagnosis. Adverse outcomes, I'm delighted you had a good outcome, but none of us would ever say that all the suffering you went through is not evidence that you had definitely morbidity and unnecessary suffering. So this is sort of my way of thinking about diagnostic errors. The thing we'll do in the next few minutes is just touch down in 8 key areas. And again, you can see how superficially we're going to do this, but just to give you an aerial photograph, Helen asked me to talk about what I thought my perspective of some of the key issues today. And we'll talk about the culture of diagnostic safety, closing loops, issue of access and capacity, continuity and the importance of that. Each of these, by the way, intersect and overlap with each other, dealing with diagnostic uncertainty, the role of patients in co-producing diagnosis. And then, of course, we have to touch on AI, and I want to put a little caution and critical thinking there, and what I call conservative diagnosis, of being careful about not over-diagnosing patients with giving them lots of tests and diagnoses that will actually be harmful. So starting with the culture of diagnostic safety, again, I apologize, we'll go through these quickly, but we thought about this, we know about culture of safety, but particularly with diagnosis, it means driving out fear, okay? So people are not afraid to question the doctor, to ask questions, to share when things go wrong. So obviously, it's quite the opposite of what we just heard. Patients are encouraged to speak up if they're concerned or not getting better, learning from adverse events. We heard about, my wife works in Rwanda. When I was there maybe about a decade ago, we heard about a misdiagnosis. The doctor was arrested and put in jail. Obviously, other health workers are not going to come forward when they have a misdiagnosis and share that. We should be working together, freely sharing the cases among colleagues and patients. Organizations need to be committing to diagnostic error. How many of your organizations, boards, know that the leading cause of patient safety, according to patient reports and malpractice claims, is diagnosis, misdiagnosis, and what are they doing about it? What are they doing to aggressively look into cases where things have gone wrong, learning from cases like the one we just heard? And then clinicians curious, what am I missing? Making this something, let's have a conference. Why isn't this patient getting better? What could we be missing? Obsession with the details of the diagnostic process. What's happening with our misfiled x-ray reports, and how can we avoid that? Further recognizing uncertainty is inherent in diagnosis. That we'll talk about this some more, but for doctors to be arrogant and be dismissive is really quite the opposite of what we needed in this case we just heard about. We need to communicate these uncertainties to the patients. We'll show you a little bit about that. And then respecting the human limitations. So these doctors who are rushed, you could sort of blame the doctor, but who put them in a situation where they only had 10 minutes to see a patient, or to do a test that takes a half hour, they only have 15 minutes, or they have to do 2 tests at once. I think I just heard that. So these are, and the EMRs have become part of the infrastructure we're operating in, and they are in some ways part of the problem now rather than the solution. We need to turn that around, and enhanced role for the patients in co-producing this diagnosis. This idea that the patients are the consumers and the doctors are the providers of diagnosis is really a flawed concept. It's co-produced by the patients and the doctors. We need to work collaboratively. So what is a culture of a good safety culture of a good clinician? These are just some, in some ways, obvious attributes, but modesty, humility, having continuing relationships, sharing uncertainty, admitting mistakes, looking at the whole patient. Was it obvious? Dinez was a hysterical hypochondriac patient. No, she had one specific problem. It's just really looking at the whole patient, following people over time, the ones who saw that the patient doesn't improve, following up, etc. And we would argue this isn't just like being nice or empathetic or compassionate, but these are the pillars of good diagnosis. The next one I want to hit on is this business about open loops or closed loops. We have been following these 3, for example, tests: referral to dermatology for suspicious for a cancer lesion, a stress test for chest pain, colonoscopy for rectal bleed. I don't know whether you want to say the glass is 75% full, or what we're saying is it's 25% empty. A quarter of the patients never had the loop closed. They have a suspicious for cancer skin lesion, and they never got to the dermatologist. Very complex. Why? This is interesting, but obvious. During COVID, this is 2020, a lot of these referrals didn't happen. Of course, that's expected, but even before COVID and since COVID, these are open loops. What can we do about this? Another open loop we did is we looked at radiology recommendations. There's a suspicious lesion on the chest x-ray. Please perform a CAT scan, or the CAT scan shows a lesion repeated in 3 months. Well, what we found, we looked at hundreds of these. This is at Beth Israel in Boston, and good hospitals. You would think they would be closing loops. 87% of the time they did close the loops, but 31 open loop cases were judged by quality experts substantial clinical risk. I guess if you're a malpractice lawyer, there's a lot of gold to be mined here. And when we had our experts look further, clinically significant lack of loop closure in 5% of the cases. We ought to know about these cases and not wait to get sued, but the loop should be closed by more reliable systems. We're trying to do that with symptoms. So this is both a conceptual model that we've recently published. And we said, patients come in with some of these symptoms: rectal bleeding, dizziness, joint swelling, cough. We want to make sure that these things get better. Many of these are self-limited things. But we think that the loop should be closed. We should be tracking these patients. And this is sort of a model where we think some of this could actually be done automatically. Somebody could put a flag and the computer ought to see whether that CAT scan was done in 3 months. But also we should be querying the patient. That could also be done automatically. Give a patient a text message, and we're working on that. So here's a little very primitive example of how we're trying to do this in a community clinic in Boston. So here are patients with weight loss and cough, epigastric pain. This goes on a nurse's spreadsheet. And we say, how soon do you want to follow them up? 4 weeks, 6 weeks, etc. And then this is tracked, improved. And obviously, if they're not improved, then it's referred back to the doctor. We should be closing the loop on symptoms, tests, and referrals. So going quickly, access, continuity, relationships. This is a whole 2-hour talk. I'm just going to give you one slide. The health of the U.S. primary care. I'm a primary care doctor, biased, obviously, but primary care is a key to what we're talking about. No one can see you now. Instead of the doctor can see you now, okay? Primary care is in serious trouble. We don't have enough doctors. People can't get access, etc. Diagnostic uncertainty, recognizing and communicating it. So we should be honest about what we're, first of all, the fact that uncertainty pervades diagnostic processes. From one of your fellow Australia clinicians. I love both of these people. Hopefully you know them, Dianez, Carmel Kroc, Marie Dam. And there's so much uncertainty in diagnosis about how the diagnosis unfolded. It sounds like there's a lot of uncertainty in your case. But the first thing is to be honest about that. So we're trying to develop, and we actually did a little pilot, an electronic tool for communicating diagnostics uncertainty. So many physicians say if you tell the patient you're not sure, you look like a bad doctor and you don't know what you're doing. But quite honestly, we have to be very candid when we do and don't know what we know and don't know. And this is a form, and Helen actually helped us redesign this, where we would give the patient, explaining that uncertainty is there. Here are your symptoms. Here's what we think it is, other possibilities, what to watch for, when should it improve? If this isn't better in 1 week or 1 month, come back. And then we operationalize this. This is for people who use Epic. This is an Epic smart form that we're using with voice recognition. So the doctor just clicks on this and talks through these 3 stars are fill in the blank components of that same form. You just saw a most likely explanation, when to follow up. And here's an example. We did this with a couple dozen patients. And so here's a patient who actually is quite similar. You have weakness in your hand when you notice you're sleeping and driving. Common course of the shooting pain just from the elbow. It's just ironic, that haunting. This is an ulnar nerve or neuropathy. This can sometimes get better. This is what you should do on physical exam. Things checked out okay, but this is sort of a leaflet. This is an actual patient, by the way, that again, just by coincidence, is very similar to Dianez's type of problem. Recommendations. This is an article that came out recently about time frames. We talked about this, what steps to take if the medication doesn't work, etc. Summarize, make a shared plan of what we're going to do to follow up. Again, going through this quickly. Next one, which we have to pause for more than a moment here, AI and diagnosis. So all of what we're saying, we don't have to worry about. We'll just tell the computer will tell the answer. We'll get rid of the doctors, and the patients will just go directly to this oracle in the internet. These are things that are really here now, generating a differential diagnosis. Pick the most likely diagnosis, read the x-rays, does as good a job as the person who might have missed yours, Dianez. Answer questions, create clinical notes. We're going to talk about that. Risk predictions. Again, I'm going a little fast, but yes, we should be aware of that, but also beware, okay? Again, very superficially, I'm going to run through these, but it's come up with a differential diagnosis that really doesn't know the clinical context and the human context. The physical exam, the computer can't examine you properly and perform that. You get an undifferentiated list of all the things that can go wrong, but it really doesn't tell you. And a really serious one is atrophy of clinical skills. So we have an 8-year-old granddaughter who went to the library, and she wrote her first report on owls. And she really got fascinated by owls. It was her school assignment. She went and found 3 books. She was the card catalog in the library, and she read these books and she summarized them and she scanned pictures and created this report. And we were so proud of her. It was such a beautiful report. Well, just for the heck of it, I went to the ChatGPT that night. I didn't tell my granddaughter this. And I said, give me a report on owls for 3-year-old, for third grade level. And of course, it generated a beautiful report here, okay? Most of the same points our wonderful granddaughter made in her report, okay? But think about what it means for an 8 or 9-year-old who are very smart, and she will know soon, if not already. You just go to the internet, you say, give me a report. No learning, no going to the library, no reading the books. What kind of learning is going to take place in that kind of environment? Yet that's really happening now. So, atrophy of clinical skills, same thing with the doctors, blindly following the advice, can't explain the reasoning. And there's been a long history of these programs where this Watson, we're going to get the answer from the computer, and it really has had minimal success. It's going to be changing now. Reading x-rays, variable quality. So we just heard about that. If it's a lousy x-ray image, you can ask AI to read it. It's going to come up, data, poor data in, poor data out, failure to double check, again, atrophy of the radiologist skills, unknown technical failures are going to be lurking there. Patients' questions, patients not even aware that they're talking to a bot. You're going to talk to what you think is a nurse, and it's going to be a computer. Patient may not give complete information, bad advice like this the doctor's got. Commercial mischief, all sorts of commercial vested interest for you to have a certain diagnosis or a certain procedure. And then just the frustration of not being able to reach a human being on the internet. I think we're all experiencing this with airplanes and healthcare in general. Going through this quickly, this is the thing that I am doing this. The last 7 weeks, my notes are created by AI. So I just sit there. It's called an AI digital scribe. And I put my phone here and we have our clinical encounter. And within a minute and a half, this is the note. This is an actual note from an encounter 2 weeks ago with a patient. And it's really pretty good. It uses voice recognition to hear what we said and then uses AI to produce the note. And here's the assessment and the plan, which picks up from my conversation, pleural effusion, prediabetes. The problem is this note missed the forest through the trees. The 2 things that are happening with this patient is she is very anxious, and we were dealing with that, and she's getting better. You sort of lose the sense of what's really happening with the patient, even though it produced a beautiful note. And I, as a doctor, am so happy to go home and have all my notes done instead of having to do them at night. But yet here's the brave new world. This is going to get better, but the seductive temptation to not review these notes for real errors, there's errors in these notes, and some of the greater concerns that we mentioned here, there's errors, especially in the assessment of the plan. What about that time to think? I go home and think about the patient at night, and there's a lot of diagnostic reasoning. It selectively decides what's important. Most of the social history it discards. So the patient tells me her daughter is overdosed on drugs, or they're planning a trip to Puerto Rico. This does not, it decides that's not important. For me, it is. The next time I see the patient, how's your daughter doing? How was your trip to Puerto Rico, et cetera? Often misses the big picture. Again, with no time to go into the details about this. And then test results, looking for closing the loop. Again, what are these algorithms? There's a signal to noise, lots of false positives. Who is going to follow up on the findings? It's going to alert you to potential missed lab errors, but how are we going to follow up on that? So in summary, this AI is basically untested, unregulated at this point. People are working on overcoming that. We need rigorous evaluation of the evidence and the harms. There's a bunch of data privacy issues that still haven't been resolved. Regulatory governance issues. Private equity is sort of coming in. There's a lot of money in this, a lot of gold in the balance pan. Biases in the training. Certain population groups have different propensity for biases. And then frankly, for you all, I think the things, you're going to look at these notes and these answers, and can you trust them? What's your user experience? What does it feel like to be on the other end? We talked about clinician skills and training and atrophy, not about reporting on owls, but learning to be a good diagnostician. and then your time with clinicians, because somebody's going to say, because you don't have to write the note, you don't need 15 minutes with the doctor only needs 10 minutes with you. Perhaps we'll see where the efficiencies go. Finally, and we're doing good to wrap up with this last point, we came up with this idea that diagnosis is sort of a, there's underdiagnosis, which we heard, or misdiagnosis, but then there's overdiagnosis and harm that can be resulting from that. This is a quote from Dr. Singh, who's really one of the leaders in patient safety. This was in the Institute of Medicine. What are we going to do about over-testing and over-diagnosis? Well, there's a lot on both sides, but there's not so much national conversation over-diagnosis and over-testing. The point is we need to find the midpoint between over-diagnosis and under-diagnosis. And I would just think about it differently. Is it really a trade-off between under-diagnosis and over-diagnosis, or are they actually two sides of the same coin? The same things that lead people not to listen to the patient, to misread those x-rays, are causing both over and under diagnosis. Again, much longer argument. You can reference our paper, and even the paper that's published that I just showed you. There's a longer version of that. If you're interested, of course, I'm happy to talk to people. And so these 10 principles really develop rethinking symptoms, learning how to use time effectively, maximizing continuity of trust, learning how to use tests and order them and interpret them more thoughtfully, creating the safety nets like we were talking about to close the loops. These are all working for under and over diagnosis. And then I think this is the last two slides. So for patients, many of whom you're representing here, or you are patients, there's 3 questions to ask. What else might it be? So, somebody will say, this is, nothing wrong with your arm, or this is a simple problem. What else could it be? What are we missing? What doesn't fit? Okay, why should this happen right after my surgery? Okay, of course, the natural history of this, etc. What critical diagnosis are important to miss? So maybe there is a rare diagnosis, but we don't want to miss this. Cerebellar hemorrhage, there's other causes of dizziness, but this is a critical one not to miss. So what are the critical red flags? Back pain. Somebody has back pain. It's just ordinary back pain. Well, sometimes it's a spinal epidural abscess, which somebody will go on to become paralyzed. So what do we not want to miss? How do we watch people? And then the systems of care. Do we have reliable closed loop systems? We talked about that. What's the safety culture in our organization? There are actually ways of measuring this now. And does the EMR and AI get in the way of efficient, timely, accurate, fail-safe diagnosis, or is it becoming part of the problem? And how can we improve it? So we've, again, rushed through this. I go through it in a little more detail in a chapter of Harrison's Textbook of Medicine. Happy to share that with anybody if they want to write me for a copy of that. And thank you very much for letting me have a couple extra minutes here, Helen.
Thank you, Gordy. That was great. I think people have a lot of questions about that. I want to move on now. Next slide, please, Harris. Yes. So Harris, have you taken back the slides? Our next speaker is Cecilia Nantume, who is a nurse midwife and public health professional, who's going to talk to us about her own experience, her own obstetric experience in Uganda, and how she averted a misdiagnosis to have a good outcome. So Cecilia, can you take over, please? Next slide, please.
Thank you so much, Helen, and thank you, everyone. I'm going to share my experience of how speaking up in a critical moment helped save the life of my unborn child. Next slide. Yeah, like everyone else, when you are told you're pregnant, you're happy, but you may also have a little bit of anxiety and anticipation. When I found out that I was pregnant, I was so happy. And being a nurse midwife, I was very confident that I understood the journey that lied ahead. I knew what tests would be done. I knew what I would expect. But despite my medical background, I was just vulnerable to uncertainties of pregnancy, just like any other woman. Next slide, please.
Your mic is off.
Oh, you're on mute.
Sorry about that. I say that I had a very uneventful pregnancy, and I was happy to have no complications in my pregnancy. But as I approached my due date, I decided to change where I was getting care to a hospital where I knew I would get relatively good care, but at an affordable rate. And I decided to go to a hospital where a friend of mine worked as a nurse midwife. Little did I know that the events leading to that visit to the new hospital would be one of the most life-changing situations in my life. 2 days before that scheduled visit, I went to the hospital, and it happened to be my last antenatal visit. But before 2 days prior to that, I experienced increased movements of the baby in the stomach. And on the very day of the scheduled appointment, I noticed a bloody discharge that usually signals that labor may begin. I, of course, concerned, I went to the hospital, and I was glad that my friend, who was a nurse, a midwife in that hospital, was also the head of the maternity unit. So I didn't have to wait in long queues to see the doctor, the obstetrician. So I was seen immediately. And the examination that the obstetrician did then showed that my baby had an elevated fetal heart rate, and it was irregular. The heart was beating faster than it should be, and it wasn't having the normal rhythm. And he conducted further tests, which did not really show the cause of the irregular and elevated heart rate. But the finding was also consistent that the heart rate was high and irregular. And what astonished me was him asking me if that finding had ever been told to me, but I hadn't remembered at any occasion of my previous appointments with my old obstetrician mentioning that I had the fetal heart rate was higher than normal. And it's later after the delivery that my husband mentioned that had actually been the case, but the record that I had with me, that I had carried to this new obstetrician, had never documented that the fetal heart rate was actually high. Next slide, please. Next slide, please. So what was so astonishing in that is that having the background of being a medical healthcare professional, I knew that having an elevated fetal heart rate, which is irregular, is an indication for one to have an emergency cesarean section. And I was happy because I was in my last trimester. I was 38 weeks. So the fetus had really grown to be able to survive outside of my body. But what happened is that this same obstetrician, having all that information, advised me to go home and wait for labor to begin, and also find a nearby healthcare facility where I would occasionally go to have the fetal heart rate monitored. And that advice really for me didn't sit well with me, having the background that I knew. So I questioned the doctor's recommendation, wondering, I asked him, how often should I have the fetal heart rate checked if I go home? And that question is what made the doctor realize that he had actually made the wrong call. And it was imperative for him to admit me to that same hospital and be monitored in the hospital. And the events over the next few hours showed that the fetal heart rate continued to climb, reaching 200 beats per minute, which is dangerously high. And the situation became critical, and a decision was made by the whole healthcare team to have an emergency cesarean section done. And thankfully, my baby was delivered safely. But it was very clear that if I had not questioned the initial decision, the outcome could have been very tragic. Next slide, please. So what I learned from this experience that I want to share with all patient advocates here and patients is that to be your own advocate, never to hesitate to ask questions or challenge medical decisions if you feel something is not right, or if you really feel you have a good reason to, and to trust your instincts. While the healthcare providers are experts in their fields, we patients know more about our circumstances. And we are best placed to know if a doctor's advice may not work as it should. And then track your health history. It's always important to ask and keep track of all the findings from your routine assessments, and you always have to pass on this information to the providers in subsequent visits to enable them come to a right diagnosis. And it's also important to always ask for explanations. Ask to understand the reason behind tests and treatment, and ask how some of these tests and treatment actually align to your symptoms and diagnosis. Next slide, please. And with this, I also have a call to action for healthcare providers. One, they should endeavor to foster an open communication, always encourage patients to ask questions and actively involve them in the diagnostic process. They should always take a patient-centered approach, remembering that the patients know their bodies and circumstances and collaborate with them in the decision-making. They should enhance diagnostic transparency, clearly explaining the diagnostic processes, the test results, and the treatment options, and empowering their patients with this knowledge. And they should continuously improve their diagnostic skills to ensure they engage in regular trainings and stay updated on the latest diagnostic technologies and best practices, which was clearly missing in the provider that I had met. And then to also provide a culture of safety, creating an environment where patients feel comfortable to challenge and question their diagnoses and the care plans that have been prescribed. Thank you. So in conclusion, this experience to me underscores the importance of patient advocacy and the need for clear communication with healthcare providers. Being able to ask specific questions and being involved in one's care plan can significantly improve the healthcare outcomes. And also it's important to empower patients with knowledge and for them to be confident to speak up in critical moments to ensure the best possible care for themselves as well as their loved ones. Thank you so much.
Thank you, Cecilia. That is a great lesson in patient advocacy. So Gordy has put in the chat a link to his email where he can send you some of these resources that are not publicly available, and we will put the ones that are publicly available on the website, as I said. So we've got just a few minutes for questions and answers. I want to ask one question of all three candidates, all three participants. What don't know where that came from. I don't. Anyway.
I do.
Okay, tell me afterward. Anyway, now one of the things that's always striking to me is the phenomenon of patients disagreeing with the diagnosis or having their concerns dismissed. And we saw elements of that in both Dinaz's and Cecilia's accounts, and yet they both in the end had good luck after some sort of scary moments or months in the case of Dinaz, but they both in the end had good luck persuading providers to see their point of view. So I'm asking the three of you, there have been many tips in these presentations, but if you had to pick out one, what would you say to patients trying to improve communication with their providers, with their diagnosticians? I'll start with you, Dinaz.
I was very, very lucky, to be quite honest, because it had happened to me before. If the left arm had only been the first time, I wouldn't have known any different. So I was just very, very lucky that it had happened to the right arm before, and I had a brilliant hand surgeon who wasn't sure what it was, but still did exploratory surgery and he reversed it. But one big lesson that I learned was to make sure you get copies of each and every single report after you see a clinician. everything.
Yeah, that's great. That's a really good point. And that's not always easy to do either. Cecilia, what do you think? What is your main takeaway?
My main takeaway in how we can improve communication between patients and providers is patients being empowered and having some information at hand before they go to visit providers, because that will help you to understand what is going on. If you go and you have no idea of what is happening to you and you can't even express what you're feeling, it becomes very, very difficult to have that interaction with providers. So I would encourage us as patients to always do our research, track how we feel and the progress of our illness, and be able to even make notes if you feel that you may reach the room and you have forgotten something. You could actually write down what you want to tell the doctor, how your symptoms have progressed, what you have been feeling, and what treatment, because sometimes you may know what you want to say, but when you reach there, because of the pain, maybe because of the rush of the system, you may forget to say some critical things. So I would encourage patients to actually do that. Thank you.
That's great. And Gordy, last
Very quickly. So one is to be empowered with information, right? Reading the chart, by the way, shouldn't be so hard. It used to be hard, but it's much easier. There's a law in the US, all those notes have to be open to the patient. Take advantage of that. Second opinions, reading information on the internet. Lots of doctors say, I don't want to see these patients. They come up with a stack of papers from the internet. We got to change that to making doctors welcome that. We're all learning together, figuring it out. And then advocacy, there's actually ways to bring somebody with you. There's patient advocates. But I want to end with something kind of a different flavor here. Doctors and patients are not enemies, right? It's not them against us, you against us, fighting for their time. We really should be in this together. First of all, to make sure we have enough time to see each other and talk and follow up, to feel non-defensive. I mean, if you come in with a malpractice gun aimed at my head or blaming me, instead, we're gonna, we need to figure this out together. We being an advocate is not being offensive and the doctor being on the defensive, but we really need to conceptualize, and doctors need to be retrained. We need to restructure our healthcare system for continuity, knowing these patients, trusting patients, people trusting each other. So that's going to go a long way to enable some of these cultural things and these process things to flourish.
That's great. Yes, an important message that we're in it together, and providers need to think about these things from the patient perspective and the other way.
I say doctors, we're talking about nurse practitioners, other clinicians.
Yeah. Okay, well, Andrew, we are right at 10 o'clock, so I'm going to turn it over to you very quickly to wrap us up. And
right. Well, first and foremost, I want to thank you, Helen. I want to thank all of the speakers. What an amazing job. This was an amazing webinar. It had it all. It had patient stories. It had the data. It had takeaways, what you can do, calls to action. I just love this webinar, and thank you all for sharing your expertise and your personal stories to us. I just want to take a minute to wrap up. Thank you all. Tell you that we have an upcoming webinar. We have a campaign, actually, and a webinar is part of it, where we are going to thank the healthcare providers, the nurses specifically. The heart of our healthcare are the nurses, and we're going to celebrate the nurses. You can see all the details on this slide. So we're really looking forward, and we're going to be working with the International Council of Nurses, and this will be a great event. So do register for this webinar on thanking the nurses and celebrating them. And also, there's another webinar coming up. You can see here, save the date, a dialogue on how to spark clinical. I'm on a phone because I'm at the World Cancer Congress. So clinical trial and policy engagements in Africa. We have a save the date on that. And of course, we're doing a lot of work in Africa. So do follow the work that we're doing with our regional committee. And next slide. of course, we have our webinar on patient safety rights charter. That's coming up. That's in December. So mark your calendars for that. We basically have webinars every month of the year now. So these are just some of what's coming up. Next slide. Should be our big in-person conference. Am I right?
Yes.
Yes, there we go. Our big in-person conference. You can still register for the virtual aspect of it. It's free. And we are sold out for in-person. We're oversold actually, so we can't register you for in-person, but there's still plenty of rooms. There's more than room to register virtually. There's more than 1,000 people who have registered. So we have an amazing 2 days coming up from Cape Town, and you can participate live virtually. So go to worldpatientsalliance.org, register for the conference. And for those who are coming in person, we look forward to seeing you in person in Cape Town in about a month. So next slide.
That's all.
That's it. Thank you, everyone. Thank you for the speakers. We'll see you at the next event. Have a great day.
Thank you all for coming, and check the resources at worldpatientsalliance.org. Thank you.
Thank you.